In the winter of 1847, a Hungarian physician named Ignaz Semmelweis walked into a maternity ward in Vienna and noticed something that should have been obvious to everyone around him for decades. Women who gave birth in the ward staffed by medical students were dying at a rate 5 times higher than women who gave birth in the ward staffed by midwives. He spent months trying to figure out why. When he finally did, he published his findings. The medical establishment laughed at him, institutionalized him, and watched him die in an asylum at the age of 47. The women kept dying, and the midwives, the women who had kept mothers alive for 5,000 years, were already being systematically destroyed. That is not a metaphor. That is a timeline. And to understand how it happened, you need to start much further back than 1847. In a world where the idea of a male physician entering a birthing room would have been considered not just unusual, but genuinely obscene, for most of recorded human history, birth was women's territory, not by accident, not by oversight, by design, by expertise, and by a body of knowledge so carefully accumulated across so many generations that modern researchers are still unpacking what was actually understood and how well it actually worked. The oldest known midwifery text comes from ancient Egypt, the Kahun Papyrus, dating to roughly 1825 BC. It describes gynecological conditions, pregnancy complications, and interventions with a clinical specificity that surprises people who assume ancient medicine was entirely superstition. Egyptian midwives, called rekhatket, meaning those who know things, operated within a formal professional structure. They trained under experienced practitioners. They specialized. They were paid. In ancient Egypt, attending a birth was skilled labor with recognized expertise behind it, not a folk practice scraped together from guesswork. Greek and Roman midwives, called obstetrics in Latin, from the verb obstare, meaning to stand before, occupied a similarly formal professional role. Cyrenius of Ephesus, writing in the 2nd century CE, produced a text called Gynecology that remained the foundational obstetric reference in European medicine for over 1,000 years. And here's the detail that almost nobody mentions when they cite Cyrenius. He was writing a manual for midwives. His intended audience was women practitioners. The knowledge he was codifying was knowledge that already existed inside a female professional tradition. He was recording it, not inventing it. Cyrenius described what a skilled midwife should know. She should be literate. She should understand diet and pharmacology. She should be able to manage normal deliveries and complications. She should have strong, steady hands, good eyesight, and the temperament to remain calm when everything was going wrong. That is a professional description. That is a job specification. And for roughly 15 centuries after Cyrenius wrote it down, that specification was filled by women across the European world without significant interruption or serious challenge. The challenge, when it came, did not come from science. It came from licensing. In 1512, Henry VIII of England passed the Medical Act, which required practitioners of medicine to be licensed by either the church or a university. That single piece of legislation contained a problem so obvious that it should have been impossible to miss. Women were not admitted to universities. Women could not receive university licenses. Women could not therefore practice licensed medicine. Midwives were initially exempted because birth was so completely outside the male medical sphere that nobody thought to include it. But the exemption created a framework. Licensed medicine was legitimate. Unlicensed practice was not. And midwifery, by definition, sat on the wrong side of that line. It took roughly a century for that framework to start actively destroying what it had initially ignored. The woman who stands at the center of this transition is someone whose name you almost certainly do not know. Her name was Jane Sharp, and in 1671, she published the Midwives Book, the first midwifery manual written in English by a practicing English midwife. She had been delivering babies for 30 years. Her book was practical, detailed, and deeply skilled. It was also written in English rather than Latin, which tells you exactly who she was writing for and exactly who the emerging male medical establishment was trying to exclude. Latin was the language of universities. English was the language of women who had learned their trade through practice rather than lecture halls. Sharp understood what was happening to her profession, and she said so directly. She wrote that men who entered the field of obstetrics were motivated not by care for women, but by profit, and that their formal education gave them theory, without the experience, that actually kept mothers alive. She was not wrong. The men entering obstetrics in the 17th and 18th centuries were called man midwives, and the term was considered insulting by almost everyone who used it, including the men it described. The profession rebranded itself as accoucheurs, a French term that carried the social weight of Parisian fashion, which in the 18th century was considerable, and the instrument they brought with them, the tool that was supposed to represent the superiority of male medical training over female midwifery tradition, was the obstetric forceps. The forceps were invented by Peter Chamberlain the Elder sometime around 1600. And here's the detail that tells you everything you need to know about the men midwives and their relationship to women's welfare. The Chamberlain family kept the forceps secret for nearly 100 years. They carried them to deliveries in a locked box. They blindfolded the patient before bringing the instrument into the room. They cleared everyone else out before using them. They rang bells and made noise during deliveries to prevent anyone from hearing what they were doing. For nearly a century, while women were dying in complicated deliveries that the forceps might have resolved, a single family hoarded the technology as a commercial secret to protect their practice income. When the forceps eventually became public knowledge in 1728, they were promoted as the defining advantage of male obstetric training over traditional midwifery. Only properly trained male physicians could use them safely. Only the university-educated accoucheur had the anatomical knowledge to apply them correctly. This argument had a small practical problem. The forceps, as used by male physicians in the 18th century, killed women and babies at rates that should have triggered immediate investigation. They caused lacerations, hemorrhage, and infection. They crushed infant skulls. They perforated uteruses. The problem was not the instrument itself. The problem was that men who had learned anatomy on cadavers and had often never attended a normal delivery before, encountering a complicated one, were applying complex instrumentation in high-stakes situations with no practical experience. Experienced midwives knew this. They said so repeatedly and in print. Elizabeth Nihal, a midwife who had trained at the Hôtel-Dieu in Paris, published a treatise on the art of midwifery in 1760 and spent considerable energy documenting the damage caused by forceps in the hands of inexperienced male practitioners. She described the instrument as a weapon of violence in hands that had never learned patience. She was dismissed as professionally jealous and unscientific. Her critique was never actually refuted. It was simply ignored. The survival data, where it exists, is uncomfortable for the official narrative of medical progress. The Hôtel-Dieu in Paris, one of Europe's oldest and most important hospitals, maintained records across the 18th century that show midwife-attended deliveries had lower maternal mortality rates than physician-attended ones. The same pattern appears in British records. Irvine Loudon, a medical historian who spent decades analyzing maternal mortality statistics across Europe and America, concluded in his 2000 study Death in Childbirth that the introduction of male physicians into routine obstetric care in the late 18th and early 19th centuries was associated with increases rather than decreases in maternal mortality in multiple regional datasets. The reason, as Semmelweis would eventually identify, was largely infection. Male physicians moved between autopsies, surgical wards, and delivery rooms without washing their hands because germ theory had not yet established why they should. Midwives, who typically attended only births and did not move between infectious disease patients and laboring women, were not carrying the same pathogen load into the room. The statistics were available. Nobody in authority was particularly interested in reading them. What was being accomplished instead was a systematic campaign to delegitimize midwifery as a profession. The tools were familiar: licensing requirements that women couldn't meet, medical education programs that didn't admit women, professional associations that excluded female practitioners, and a sustained rhetorical campaign in medical journals and popular publications suggesting that traditional midwifery was ignorant, superstitious, and dangerous. a characterization that required ignoring several thousand years of accumulated practical expertise and several decades of survival statistics pointing in the exact opposite direction. William Smellie, one of the most influential British accoucheurs of the 18th century, described midwives in his 1752 treatise on the theory and practice of midwifery as ignorant women who were no better than brutes. He wrote this in a textbook that was used to train male practitioners who had, in many cases, attended 0 actual births before receiving their qualifications. The irony appears to have been invisible to everyone in the room. The American situation in the 19th century followed the same pattern, with additional speed and additional brutality. In colonial America, midwives delivered the overwhelming majority of babies, and had done so since the first English settlements. The maternal mortality rate in colonial America was high by modern standards, because everything was high by modern standards. But it was not dramatically different from European rates, and it was not evidence of incompetent midwifery. It was evidence of a world without antibiotics, blood transfusions, or any understanding of sepsis. The professionalization of American medicine in the 19th century proceeded with a specific agenda. The American Medical Association, founded in 1847. The same year, Semmelweis was discovering the hand-washing connection in Vienna, committed almost immediately to the elimination of midwifery as an independent profession. The argument was not primarily clinical, it was economic. A birth attended by a physician generated physician income. A birth attended by a midwife did not. The expansion of physician-attended delivery was a market capture strategy dressed in the language of public health. The man who said this most directly was Joseph Delly, a Chicago obstetrician who in 1920 published a paper in the American Journal of Obstetrics and Gynecology arguing that normal childbirth was inherently pathological and required routine medical intervention to manage safely. His proposed standard delivery protocol included sedation, forceps, delivery, episiotomy, and manual removal of the placenta as routine procedures for every normal birth. He described the attending obstetrician as analogous to a bystander who catches a falling baby, implying that without the physician's active management, the baby would simply fall. The paper was enormously influential. The protocols he described became standard American obstetric practice for decades. It is worth noting that the episiotomy, a surgical incision Delly promoted as routine, was not studied in a proper randomized controlled trial until 1984, when it finally was. The trial found that routine episiotomy caused more damage than it prevented. The procedure had been standard practice for 60 years, based on the authority of Joseph Delly's opinion rather than any clinical evidence that it helped anyone. Meanwhile, the midwife elimination campaign moved into its legislative phase. Between 1900 and 1930, American states systematically passed laws restricting midwifery practice, raising licensing requirements to levels that rural and immigrant midwives could not meet, and in some states banning independent midwifery outright. The campaign was not evenly applied. White immigrant midwives in northern cities were targeted early. Black midwives in the rural South, called granny midwives, were initially tolerated because they served populations that white physicians did not want to serve and could not profitably access. As soon as hospital birth became economically viable in black communities, the granny midwives were eliminated too. Annie Lee Logan, a black midwife in Alabama who delivered over 1,000 babies across 4 decades without losing a single mother, was put out of practice by state licensing changes in the 1980s. She was not replaced by a better alternative. The communities she served became medically underserved. The maternal mortality rate in those communities did not improve. In many cases, it got worse. That detail is not an edge case. It is the pattern. Maternal mortality in the United States today is the highest of any wealthy nation. An American woman is roughly 3 times more likely to die in childbirth than a woman in the United Kingdom, and roughly 10 times more likely to die than a woman in Finland or Norway, countries that never fully dismantled their midwifery traditions. In the Netherlands, where midwife-led care remains standard for low-risk pregnancies, maternal mortality rates are among the lowest ever recorded in human history. The obstetric model that replaced midwifery in America on the grounds that it was safer has produced, by every available metric, dramatically worse outcomes. The World Health Organization recommends that midwives attend the majority of low-risk births. The evidence base for this recommendation is extensive. Decades of comparative data showing that midwife-led maternity care produces equivalent or better outcomes for mothers and babies at significantly lower rates of intervention and complication. In countries that follow this model, it works. In countries that dismantled their midwifery traditions in the name of medical progress, the data is a quiet catastrophe that most people have never been asked to look at. Semmelweis died in an asylum in 1865. Possibly beaten by the guards, possibly from the same infection he had spent his career trying to prevent. The historical record is genuinely unclear on this. His hand-washing protocol, which had reduced mortality in his Vienna ward from roughly 10% to roughly 1%, was not formally adopted by the medical establishment until years after his death. He had been right. The institution had been wrong. The women had paid the price of that wrongness in the most direct possible way. Jane Sharp's book sat in libraries for 3 centuries before historians started reading it seriously. The Kahun Papyrus spent decades in a museum storage facility before Egyptologists understood what they were looking at. The granny midwives of Alabama were put out of practice by paperwork. The survival statistics that showed midwife-attended birth was safer than physician-attended birth were available for decades before anyone in authority found them inconvenient enough to act on. Every chapter of this story is the same chapter, a body of knowledge, accumulated across centuries of practical expertise by women who had their hands on the evidence every single day, was declared illegitimate by men who had their hands on the licensing apparatus. The expertise did not disappear, it was suppressed, discredited, and in some cases literally made illegal. And the metric that would have settled the argument, how many mothers survived, was either not collected, not published, or not listened to until it was too late for the women it described. There are approximately 300,000 maternal deaths worldwide every year. The World Health Organization estimates that the majority of them are preventable with skilled birth attendants. The definition of skilled birth attendants has been one of the most politically contested phrases in global health policy for 30 years, because it determines whether a midwife counts or whether only a physician counts, and that determination shapes funding, training programs, and access to care for millions of women in low-income countries. The argument that played out in 18th century London lying in hospitals and 19th century American medical associations is still being had. The midwives are still making the same case. The evidence is still pointing in the same direction, and the institution is still, in many places, not particularly interested in listening. Jane Sharp said it in 1671. It is worth saying again. The women who have been doing this the longest, who have the most hands on the evidence, who have kept the most mothers alive across the longest stretch of human history, have never been the problem. The problem has always been who gets to decide what counts as knowing something, and who benefits when the answer excludes the people who actually know.